Thank you for joining me today. My name is Jennifer Geremia. I'm a gastroenterology physician assistant in tertiary care in Boston. I've been taking care of GI patients now for nearly 20 years, both in the community and tertiary care settings. Thanks for having me. So today, what I'd like to address is some of the more common questions that primary care APPs generally ask me about fatty liver or MASH. First, one of the most common questions that we get is surrounding identification and how to utilize non-invasive testing. And I think in the primary care space, the call to action is really to use FIB4 in high-risk patients that have metabolic disease such as obesity and diabetes. And FIB4 is a very easy calculation that you can integrate into your EMR utilizing labs that you already order. So that encompasses the patient's age, AST, ALT, and platelet count. Now, there can be some limitations, but this is not overly burdensome to your practice because, again, you're already ordering these exams. You can plug them in easily into a lot of medical app calculators, or again, integrating it as a dot phrase or templates in your EMR. And at least you know you've done your due diligence. You know, you screen your high-risk patients with metabolic disease for hyperlipidemia. We may do stress tests for cardiovascular health. We are doing, eye exams and foot exams in patients with diabetes, but often the liver is the forgotten one. And so adding the liver to your check sheet in high-risk patients and going ahead and adding just a FIB4. And if that FIB4 is indeterminate or high, there are next level non-invasive testing such as ultrasound elastography or serum ELF testing. But I would say if this is reasonable that this may be burdensome because it's not something you do every day, then go ahead and refer out to GI to help with that. Please go ahead and start with FIB4. Now, what about we've, started with FIB4 and the patient's low in the range of low, indeterminate, or high? What do we do with that information? Do we just sort of say, okay, you're low, we don't have to worry about this? No, this is what we have done for years. We've been very passive and sort of told our patients, by the way, you have fatty liver, limit how much alcohol you drink and try to lose some weight. This has sort of been the conversation for many, many years because we didn't have anything else to offer them. However, much like you would encourage a diabetic to lose weight and modify lifestyle, now, taking into account there can be lean NASH, or you incidentally stumble upon steatosis because you've ordered abdominal imaging for other reasons. But what do we then do? So we've identified the at-risk patient or incidental steatosis. We've now done a FIB4 and they're low. Does that mean our work is done? No. Next step is you want to make sure that you recheck that. Guidelines tell us about 2 to 3 years. I personally do it yearly because these conditions are fairly chronic. We know in terms of modifications of lifestyle that you need a minimum of 7 to 10% total weight loss for there to be a reduction in steatosis and any potential associated fibrosis. So when you talk to patients about lifestyle interventions and weight loss, we really want to sort of address it in this concept of percentage because that's how we look at risk reduction and response to any methodology of weight loss, including lifestyle. And lifestyle is always sort of that cornerstone piece, even if the patient has other adjuvant interventions for weight loss, whether that be pharmacotherapy or surgery. So we want to let them know, hey, this is what you need in order to keep your liver healthy and reduce this comorbid risk factor and revisit that, right? And as far as alcohol, we want to limit to about 20 grams per day for women, 30 grams per day for men. So it's not a matter of no alcohol. If you do think that the patient has concomitant liver disease due to abnormal LFTs, even if that FIB4 is normal, go ahead and do a liver workup or refer out. But I think starting point, FIB4 in these high-risk patients and really have that conversation about lifestyle and what a meaningful response in lifestyle is for their MASH and MASLDs. I hope this was helpful in terms of addressing some of the most common questions that primary care providers have in addressing MASH patients. Thank you.